good evening to all others who are joining from the rest part of the world. Today, our guest speaker for the day is no other than Dr. Regis Pifault de Lator from Paris, France. And he's going to lecture us on differential diagnosis between inherited and acquired bone marrow failure. This webinar is brought to you by Mumbai Hematology Group, supported by Zydus dedicated to life and managed by Perfect Square. I thank Mr. Ashish Kumar, Mr. Sumit Madan and the team Zydus, Mr. Yash, Mr. Kalpesh and the team Perfect Square, Executive Committee of Mumbai Hematology Group. Our chief guest for the day, Dr. Fahima Hassan from Prayagraj. Our guest speaker for the day, Dr. Regis Pifault de Lator from Paris, France. All our discussants who are themselves very eminent hematologists as well as pediatric hematologists, and you participants for sparing a Sunday morning, afternoon or evening from whichever part of the world you're logged in. Let me give a flavor of our next weekend activities. Next Saturday, that is 24th of May 2025, from 5:30 p.m. Indian Standard Time and 8 m. Eastern Time, we have got first lecture on immune thrombocytopenia from thrombopoietin receptor agonist to novel therapies by Dr. Hani Al-Samkari from Boston, USA. And the second lecture is on smoldering multiple myeloma, that is again on Saturday, 7 p.m. onwards, and Eastern Time, 9:30 a.m., 24th May 2025, by Dr. Rajshekhar Chakraborty from Colombia. And following date, it is Sunday, 25th of May 2025, 11:30 a.m. Indian Standard Time. You Dr. Gaurav Prakash from Chandigarh speaking to us on precision medicine in lymphomas as I practice in India. Let me introduce our discussions for today, and they are displayed here in alphabetical order. I pause for a while for you to have a look on all our discussions for the day. So these are our discussions for the day. And now it's time to introduce our guest speaker for the day. We are no other than Dr. Regis Pifault de Lator from Paris, France. Let me introduce Dr. Regis. I had a wonderful time with Dr. Regis in France this time. It's my formal duty to introduce him. He's the head of the hematology and bone marrow transplant department, Hospital St. Louis, Paris, France. Dr. Lator received his MD degree from University of Paris, Larry Boissier in 2003 and his PhD degree in immunology from Pasteur Institute in 2006, where he worked on regulatory T cells in graft versus host disease after hematopoietic stem cell transplantation. He was trained in hematology at Paris hospitals and did his postdoctoral fellowship at Hematology Branch, National Institutes of Health, USA from 2008 to 2010 on aplastic anemia and paroxysmal nocturnal hemoglobinuria. He obtained his tenured professorship position in 2014. He is responsible of the French Reference Center on aplastic anemia and PNH, as well as of the French Organization for Rare Hematological and Immunological Disorders since 2016. He is currently the head of the Hematology and Bone Marrow Transplant Department at Hospital St. Louis, Paris, France since 2022. His research interest focuses on bone marrow transplantation, bone marrow failure, and paroxysmal nocturnal hemoglobinuria. He is the principal investigator of many research studies on bone marrow failure at the national as well as international level. He is the author as well as co-author of more than 350 papers quoted in PubMed and is a regular reviewer for journals like New England Journal of Medicine, Blood, Hematologica, British Journal of Hematology, Biology of Blood and Marrow Transplantation, and Bone Marrow Transplantation. Today he is with us and is going to lecture us on differential diagnosis between inherited and acquired bone marrow failure. But before he does that, we have a special guest and chief guest for the day, no other than Dr. Fahima Hassan from Prayagraj. We all know Dr. Fahima Hassan very well. It's my formal duty to invite Dr. Fahima Hassan and to introduce her. She's a consultant hemato-oncology and bone marrow transplant physician, associate professor, United Institute of Medical Sciences at Prayagraj. Dr. Fahima Hassan completed her DM in clinical hematology from the very prestigious Sanjay Gandhi Postgraduate Institute, Lucknow in 2021, where she later served as faculty until 2023. With a deep passion for both classical and malignant hematology, Dr. Hassan is actively involved in clinical practice, teaching, and research. She has won multiple national quizzes, best oral and best poster presentations at numerous renowned hematology conferences. She has co-authored several research publications in peer-reviewed journals. She is an enthusiastic educator and advocate for hematology awareness. She actively engages in social media outreach, workshops, conferences, and medical camps to improve public and professional understanding of hematological disorders. Today, she is with us, and I welcome Dr. Fahima Hassan to invite and inaugurate and give some words of wisdom for this webinar. Well, I thank you very much. I stop over here. Over to you, Dr. Fahima Hassan.
Good morning, everyone. That was quite an over expression of what I am. I'm just a young hematologist, and I still remember how twinkly eyed I was as an MBBS student looking at Dr. Agarwal's speech, and that actually motivated me to take hematology as my passion and as my profession. And I'm sure even till now, especially since COVID times, his weekly webinars have been so informative that I think we can ditch the DM and really listen to these classes and just go to the wards to see the patients has been so insightful to us. And it really did help me in clearing my super specialty examinations as well. And I'm sure Sir is continuing to inspire minds of young hematologists and all the undergraduates and pushing them towards hematology. So, really good thanks. And it's indeed a huge honor for me to be a chief guest in a platform where I have been, following up since my post graduation. Utmost thanks and gratitude to MB Agarwal sir, Mumbai Hematology Group, and Dr. Kurana sir for this opportunity. And today's talk is also very close to my heart. Um, we always have a realm of aplastic anemia and pancytopenia has always been with hematologists. Even though we share leukemia, lymphomas with medical oncologists, this has always been our forte, and most of the pancytopenias anyway lands up in our bench. And it's always a problem differentiating whether we are dealing with the inherited bone marrow failure or it's an acquired aplastic anemia. And I'm really excited to listen to this from none other than D. Latour. And I also want to say all the participants, all the young minds and young faculty that this is such an immense platform for, sharpening our minds and, asking all forms of doubts. And I don't think there is any more better academic ground than this weekly webinars to, really hone our skills. And without much taking much time, I hand over the stage with utmost respect and honor to Prof. D. Latour to enlighten us on this really exciting topic. Thank you, sir.
Thank you, Dr. Fahima Hassan, for the wonderful words of wisdom. You are always kind enough. You have joined almost all our webinars, and you're a wonderful academician, wonderful clinician. Thank you so much. And above all, wonderful person. Thanks a lot. Sir, the screen is yours. You may go ahead.
Thank you very much. First of all, for the invitation, it's really an honor to be invited in a way quite frequently by your society, and there's a really kind moment to share our experience and the way we are treating patients all together. So do you see my slides?
Yes, sir. Please go ahead, sir.
And they are going, it's okay? I can go?
Perfect.
Okay. Okay, good. So the task for today would be to make the diagnosis between acquired and inherited bone marrow failure. This is not an easy one, and this is something we are facing every single patient with pancytopenia. And I would say that the main question behind that is clearly who should we search for germline mutations, because the clear idea is to differentiate between patients who are coming in with an acquired aplastic anemia that the treatment will be probably immunosuppression or transplantation if sibling is available. But on the other way around, you have in the bench of those patients, some patients who have a clear gene defect, and that for those patients, immunosuppression will be useless and possibly dangerous because you will make them at risk not being transplanted quickly. So that's a very important questions on our daily care. So those are my disclosures. So as you can see, this is the round of disease that we will go through, and how to differentiate them, because the presentation is quite the same. All those patients are presenting with pancytopenia, and on one side you have patients with inherited disorders such as Fanconi patients, diskeratosis congenita, or even Schwarzman-Diamond syndrome, whose patients about 20%. We know that one patient out of five with aplastic anemia is suffering from a gene defect, from an inherited disorders. On the other way around, we have 80% of the patients who are presenting with an acquired aplastic anemia, with something quite acute, immune mediated, no way on that. And but the presentation is the same. So it's very important. And on the other way around, we know that all those diseases, inherited or acquired, are able to complicate to MDRs or AML. It's about 15%, 10 years of our patients who are going to it, and the risk is the same from inherited to acquired disorders. So I would say it's a very frequent question, and it's not addressed properly. I mean, it's not so frequent to have a kind of exchange of courses, education on our practice in those patients. And I can tell you, it's not only a pediatric question. We have many questions, 25, 30 years old, that are coming to us. And when you're coming to do the kind of, questioning and examining and all the things that we are doing, exploring a plastic anemia, we see that there are some possibly clues that make you think that those patients, even adults, might have a inherited disorders. That will be what I would like to point out from that talk. What is sure is that it should be systematic in young patients. Young means pediatric. We have to really, really, really keep in mind this question, and that definitely be eliminated before proceeding to treatment. And I don't find it simple because, of course, we have tools. We'll see. We have breakage tests. We have genetic tests. We have flow fish for telomere size. We have all those fancy things. We have 6p-LOH, we have PNH, but in the end of the day, I mean, it's not always so easy, and sometimes it's quite tricky because you have those very little clone of PNH, but then in the family there is another case of cirrhosis that was not alcoholic driven. So yeah, what should we do? I mean, the telomeres are not less than 1 percentiles, but they are between 1 and 10. So you see, it's not always easy, and it's really important. It's really important because, first of all, we need a diagnosis for our patients. I mean, we are so reassured as physicians when a patient is entering in a box. I'm not saying this in the wrong way. I'm just saying that it's more comfortable for us because we know the patients will then receive the best treatment, the best management. We know that in the end, he will have the best treatment we think he will merit to have, even if it's not always working so well, but at least we know what we are treating. And that's the reason why we need a systematic flow up at the very beginning to eliminate and to try to find a way to discriminate between inherited and acquired. The other thing is that you're not treating the same way an inherited disorders and an acquired BMF. I mean, this is typically different. I mean, for young patients with an acquired aplastic anemia, if you have a no donor, you will go to immunosuppression. And if these patients have a gene-related BMF, you will make them at least last 6 months, at least, because you will also expose your patients to complications that was not supposed to expect, sorry. The other the other reason why it's so important is definitely the transplantation setting. I mean, I heard that there are many transplanters, I mean, in this field, and from the very beginning, from the history of BMF management, most physicians who are taking care about those patients are transplanters because we didn't have nothing else to propose at the very beginning. And then, of course, we acquired knowledge, tools, treatments, and then progressively we were able to propose something else. But when you're going to transplant an inherited disorder patients, you have to do carefully because there is not the same way you're doing when you are transplanted and acquired disorders. Let's look for the dose of cyclophosphamide, for example. we do know that Fanconi patients are unable to receive high-dose alkylating agents. So if you are proceeding to a Fanconi patients with a sibling donor using the usual cyclophosphamide 200 milligram per kilo cyclophosphamide, well, you're going to kill the patient. So you see how important it is to make the diagnosis. The donor choice, I mean, if you're proceeding systematically saying, well, that's cool, I have a plastic anemia, there is a donor, the patient is age less than 40 years, let's proceed to transplant, no worries. And then in the end, there is a gene in the family, and you're using a donor that has also the disease. I remember perfectly this clinic I was doing, it was 15 years ago with Gerard Associé, that most of you know. We are receiving these patients with his donor, they were brothers. And basically, the brother was smaller than the patients itself. It was Fanconi patients, and obviously the other one is Fanconi too. So imagine if we've got transplanted them. I mean, of course, it would have been a drama. So that's again why it's so important. And the other thing that we have to keep in mind is that if you're coming to genes, you're coming to a syndromic presentation. The patients is suffering from a gene-related disease, and most of the time, it's not only hematopoietic. You're not only facing blood disorder, you're also facing a whole blood gene disorders and syndromic presentations that can be liver, they can be cardiac, especially heard in Fanconi patients, can be kidneys with only one out of two in Fanconi patients. So in this keratosis congenita with those devastating lung attempts and liver attempts. So you see the consequences. So that's the reason why it's so important. And the other thing that we have to think about, and then of course, more and more we have some genetic conceal. And it's not genetic conceal, it's really conceals. It's plural. Because you have to see the entire family. You have to look for the gene in the donor as quick as possible, because we know that the SIB donor is better. But if the SIB donor is also a patient, then it's a problem. And we have to go through the entire family to prevent the complications and then the possible occurrence of the disease. So that's why I think this talk is important. That's are my views. You'll see during the talk that possibly I'm missing stuff, possibly you are doing differently. And I think this is also important to share and again, to share experience and to see what is the best to do. So I'm going to have to say to you what we are doing from the initial diagnosis and then to these fundamental questions to discriminate between acquired and inherited. So the first very easy way, I mean, and I would say that something we could not miss is a diagnosis of aplastic anemia. First of all, I mean, this is not difficult. This is a patient that is presenting to you with pancytopenia, usually young, and in those patients, the diagnosis is quite quick. First of all, you look on the CBCs. There is a microcytosis that won't orientate to anything. The microcytosis in pancytopenia is very common. This is not in favor of acquired or inherited. This is something common, and that's it. The lymphocytes counts is already I would say, possibly an indication, because you'll see that in acquired disease, the lymphocyte counts are usually normal. Are usually normal because this is a disease-related effect. So in other words, we know that acquired disorders is an immune-mediated disease driven by CD8 cytotoxic T cells. So it's quite normal that you are finding normal counts because in the end they are strong and just destroy them out with stem cells. On the other way around, for inherited disorders, you could have some immune system deficiency, and more, we're observing some uh, um, immune presentations for inherited disorders. The other thing that is not common and would say quite global, inherited or acquired is the type of cells primarily involved in the disease. This is platelets, and this is always or sometime when there is only one lineage that is beginning is the platelets and beginning with a thrombocytopenia. And this is something that is important because then you could make the difference with MDS. Myelodysplastic syndrome, of course, is older patients, but we know that we have a peak of aplastic anemia for about 55, 60 years of age. But the primary lineage is always red cells, it's anemias. So for aplastic anemia, whatever the cause is thrombocytopenia. So then, of course, you're doing a marrow aspirations, and that's really helpful because you're not gonna eliminate any inherited acquired disorders, but at least you're gonna make the difference with MDS and AML. So in one day, you will have already eliminated at least patients with acute myeloid leukemia or acute lymphoblastic leukemia and myelodysplastic syndrome, and then the diagnosis, and that's extremely important. All patients with aplastic anemia should have in their charts a bone marrow biopsy, and only one, please. Most of the time, we see physicians repeating bone marrow biopsies. This is painful. This is really something that is possibly dangerous. This is really not agreeable to receive this, and it's useless to repeat it. We did need one. We did need one to make the formal diagnostic of aplastic anemia. And then you see how it is. It's an empty marrow. You see that the niche are not fully blushy with stem cells. They are just adipocytes. And that makes a difference. That makes the diagnosis. And that also makes the differential diagnosis with fibrosis. Because you could not eliminate a fibrosis, a myelofibrosis, by marrow aspirations only. Not only because you could not aspirate, but also because it's very difficult. So then, if you have a bone marrow biopsy well done, or showing an hypocellularity, less than 30%, this is a matter of severity. This is something important because then you have a clear diagnosis of aplastic anemia. And I would just say that be careful not to overestimate your biopsy. You can have a dyserythropoiesis. This is completely normal and usual. Those patients with aplastic anemia have some red cells that might be qualitatively wrong. I mean, you could have some dyserythropoiesis. However, it's not possible. It's a disease if you have these kind of signs on the neutrophils and on the platelets. So basically, for red cells, there is erythropoiesis in aplastic anemia is usual, especially if you have a PNH clone, and the other things not, and the other things make you think about MDS. You can have some mastocytes, of course, lymphoid hyperplasia, because this is the main disease driven for acquired disorders. Plasma cells, possibly, and macrophages. And I remember perfectly those patients referring to us for a macrophages activated syndrome, but in the end, it was aplastic anemia with an infection because of neutropenia. So, first of all, doing the diagnosis of aplastic anemia, quite easy. You are eliminating AML, MDS, and myelofibrosis. And then now, this is a problem. Because basically, whatever the cause is, the presentation is the same. And you will have the exact same bone marrow biopsy if it's acquired or inherited. And you know that one patient out of five will have a gene-related disease. So how could you deep into this? How in could you dive into this? So I'm again giving how we are proceeding, but I would be more than happy to hear what you are doing. So first of all, we are really very systematic at the first glance. We are really asking many questions to those patients where they are coming in. First of all, for the hematological profile, this is outstandingly important. Inherited disease, gene-related disease are mostly progressive disease. You have to check all CBCs in those patients, and you'll see that if you're looking carefully to those CBCs for inherited disorders, most of the time the aplastic anemia is moderate and progressive. You will see the platelets are decreasing slowly, and then you see that the red cells, the hemoglobin level are coming in, and then the neutrophils. So that's something typical. On the other way around, when you have an immune-mediated disease, an autoimmune-mediated aplastic anemia, this is acute. This is a thunderstorm. The patient is doing great. I remember perfectly this singer. He was performing 80 dates per year. He was wonderfully doing. And from a day to another, I mean, he was not able to come on stage. It was incredible. It was outstandingly tired. It was in acute form. And this one, obviously, was an immune-mediated disorder. The other thing that you have to look for is definitely family history. I think we are not systematic enough. We are running to scanner, MRI. We are not speaking with patients anymore. We should speak with them. We should ask your aunt, your aunt, your uncle, your grandfathers, how they were doing. Tell me what was, if there are any hematological profiles, disease, what we are hearing about them. And sometimes we'll find, you know, some families I don't want to speak about cirrhosis because cirrhosis is usually driven by alcohol. I mean, in the popular way, popular mind, and this is something a bit of shame, right? And there is cirrhosis related to this keratosis congenita and telomeropathy. So you have to ask them, is there is no liver disease, there is no lung disease, is there is any form presentation in the mouse, is there any cancer in young patients? You have to ask this. That's the reason why I put a little policeman. It's really something very, very systematic, and the questioning is important. The physical exam is also important, and this is for a youngest hematologist. I mean, please, I know you like blood, but like your patients, you have to examine the entire body. You have to look for the skin. Is there any tache café au lait that are very helpful because then you are doing the diagnosis of Fanconi anemia without any bloody expensive gene panel, right? And that's important. You should look for the birth, if there any growth retardation, which is really in favor of inherited disorders. Is there any malformation? Look for the hands, look for the kidneys, look for everything you could to see if there is no extrahematological problems that make you think to syndromic presentation and not to a simple aplastic autoimmune mediated disease. Look for the skin, look for the liver, look for the lung, and so on. You may need some very simple exams to verify. You could do ultrasounds. I'm usually doing, honestly, systematically an abdominal ultrasounds to see if there is two kidneys, because this is not something I could verify with my hands. Because when you have only one kidney, you know, young patients, only one kidney, might be a Fanconi patients. And I'm also doing some systematic cardiovascular assessments because you may have some malformation here. This is noisy, so some usually you don't find you don't I mean you know it, but we never know. So sometimes I'm doing it also to check if there is no malformation. And then of course you come to the biology and you have some clues that might help. The hemoglobin F is something helpful, absolutely not specific, but you know that might be a little bit elevated in inherited disorders. And then you have the other things, and we'll spend a little bit of time on PNH, loss of heterozygosity, and TSR clonal rearrangement to make the difference between, again, inherited disorder and acquired disorder. So PNH, I mean, I know that was not the topic of the day, but how could I not speak about that disease that I'm passionate with? So, it's a gene related disease, but a somatic mutations, acquired mutations during time in the PGA gene. And as you know, this gene is coding for an enzyme that's responsible for the synthesis of a glycophosphatidylinosyl anchor, and that is attaching at the cell surface many molecules. You see that there are details there. There are many migration, activation, and so on. And there is, of course, I would say, the inhibitors for complement activation, like CD55, that is stopping the activation at the early phase of complement activation, and CD59 that is blocking at the terminal phase of the complement activation. So you know that if you don't have those inhibitors, since the complement is constitutively activated, I mean, then you will have hemolysis, and mainly related on red cells, because basically those cells have no other complement inhibitors available to protect the cells. For platelets, for example, it's a little bit less severe because you have CD46 that is helpful, and CD46 that is protected a bit against complement activation. That's the reason why this disease is mainly expressed on red cells. But that's not what you want to hear today. What you want to hear today is that this PNH clone is not expanding everywhere. I think that we will all have during our life a PNH clone. But this clone is not going to able to expand because we don't have, and still we hope we don't have, an autoimmune mediated bone marrow failure behind. In other words, this PNH clone is able to expand only in immune mediated aplastic anemia. If you look to this scheme that was elegantly done by Bruno Rotori and Lucio Luzzatto, you see that with time the PNH cells are going to expand and to replace the normal cells. So what we do know, but again, it's an observation because we don't know why. That's what we are looking in my lab um, to try to understand if you're doing a marrow sampling in a PNH patient, in a plastic PNH patients, you will see some apoptosis marker on normal cells. Highlighted what I was telling to you, the immune-mediated process with the cytotoxic T cells who are, in a way, destroying the stem cells. But you won't see any apoptosis markers on PNH cells. The PNH cells are protected. So the PNH expansion is a natural way to evade, to escape the natural, I would say, to escape the immune attack. And then PNH is replacing with time all those cells that are destroyed by your immune system. So that's the reason why all the treatment will target PNH cells and destroy those cells in aplastic anemia will just worsen the disease because then you won't have any immune evasion possibly. And that's the reason why definitely those cells is a way to immune evade the attack, and then why it's so a good marker for immune-mediated disease. On the other way around, and more recently, we describe another way of escaping the immune attack is acquired copy number neutral loss of its heterozygosity. That was coming from Japan. They were looking on many, many patients who were presenting or previously treated with aplastic anemia. As you can see here, it was about 300 patients, 107 newly diagnosed, and about 200 who were previously treated. And what did they found in 30% of the patients is a loss of one HLA haplotype. And why it's so important, this loss of the 6P, is that then if you don't have this haplotype, you don't have the presentation of these HLA restricted antigens. And what was shown in those patients is that it was not coming in random alleles. It was coming in specific alleles. And when we were looking for those alleles and the disease distribution, it's not showing here, but if you come to the paper, you will see it. You see those alleles that were associated with the aplastic anemia. And so the idea, as you can see on this little scheme, is that with this loss of heterozygosity, then the cells who are, let's say, mutated or who lost the entire haplotype are not able to present the antigen because of these mutations, and then they are protected because then, of course, the immune system is not seeing it, and then they're expanding. So this is another, I would say, immune escape mimicking the PNH clone and highly associated with immune-mediated disease that has been confirmed by many groups. And I find it interesting because it's, again, a kind of biomarker of immune-mediated aplastic anemia. And there is this nice paper that show up not so long time ago on almost 500 patients, and they were looking on not only PNH clone and 6P LOH, but also T-cell rearrangement, because you know that when you have an autoimmune disease, you might have some TCR rearrangement that makes them think that the disease is mediated by autoimmunity. And as you can see here, I mean, of course, if there is no signs, there cannot say anything, but when it's present, PNH or 6P LOH, this is outstandingly in favor of an acquired disorder. So you see how it's something important, helpful in the diagnosis of those patients. And you see that the TCR rearrangement was not so associated with disease. So all that to say that on the biological side, PNH and 6P LOH is something that can be helpful. 6P LOH is not routinely done. It's not so easy. And even in our labs, we are trying to make it work. But for the moment, this is something that we're not going to do routinely outside research. So then how for the other disease we can do the diagnosis? So obviously this is a Fanconi disease. You see these mispresentations of the kidneys that you can usually and easily see at the ultrasounds presentation. You see why the physical exam is so important with those presentation of patients that are so in favor of Fanconi, those very nice little faces, the problem of the hands. This is something that might help to make the diagnosis. In terms of tests, those patients will be negative for PNH. They might have an hemoglobin F that maybe have a level. The alpha fetoprotein will be also elevated. But the specific test will be breakage test, something very easy to do, very quick, that we can do everywhere. Then we can move to the FANC D2 test, sorry. That is the formal diagnosis of Fanconi anemia, but if you have a breakage test with many physical suspicion, this is something that already make you think about. And of course, we are also doing some genetic screening on germline material only. So we are doing fibroblast culture for 3 weeks, and then DNA extractions, and then running to the genetic panel. For this keratosis congenita, as you know, this is some repeated sequences at the end of the telomeres that are protected during the chromosome division, protected chromosomes to avoid them to be with time a bit shortened. So you can see that there are many proteins that are involved in the protection of those telomeres, and especially sheltering, and each of those proteins can be mutated. And of course, these mutations will then alter their function, and then, of course, drive to some telomere problems, shortness, and then the patients will present the problems related to telomeres. So this is a kind of presentations of those patients, and again, why this is so important to do the physical exam in your patients. I mean, for the young people who are attending this seminar, please continue to examine your patients. This is the heart of our work. This is the heart of our specialty. We should continue to look on your patients, even if we are blood specialized. You see that you have some abnormalities on the fanners. You see that the skin is not normal. You see this lichen and leukoplakia in the mouth. So we have to make them open the mouth and look carefully if you have some signs in favor of an inherited syndromes. I mean, this is so impactful. I remember perfectly these patients who was coming to our unit for transplant. He has a sibling donor. He was almost conditioned. We were putting the catheter, and when he entered, I remember perfectly, an old lady was an old doctor in a unit. She was coming to him, and she sees this hyperpigmentation on the skin, and that was typical. And this patient, I mean, he was going for 200 milligram per key of cyclophosphamide, and she said, well, you know, that might be a dyskeratosis congenita. And that was a dyskeratosis congenita. And this patient's got 15 years of surviving without complication, while he would have probably died in horrible complications for transplant in some months. So that's, you see how it's important to check our patients. And you can see all the genes. There is one gene after another, and then now there is many genes that have been identified and looked for, and that are associated with that disease. So at the moment, how we are proceeding in France, we are sending 2 samples, one for the flowfish in Robert Debray to check the size of the telomeres, and at the same time we're sending some DNA, germline DNA, to Professor Canon G's lab to check for genes. So we're doing quite at the same time, trying at least, of course, to focus the gene panel assessment once the telomeres are short. This is the overall pictures of all the patients we have screened so far. As you can see, we have about 166 patients who are presenting with telomere lengths less than 1 percentile. So for sure there is a problem. And in these patients, there was about almost 140 patients who had a gene panel with 95 mutations identified. And you see, there are some patients who have very short telomeres, who don't have gene yet. But when you have less than 1 percentile, you can say it's a telomeropathy. And you see the type of genes, there is no surprise. TERT, the first one, TERK, LTL1, TIMF2, DKC1, and others. And you see how this distribution of the patient with our short telomeres, they are below the normal, while the gray patients, LC controls, are presenting normal telomeres with long telomeres. The message here is also, as I was telling to you at the very beginning, they might have some patients that have between 1 and 10% percentile. So medicine is not so clear cut, and of course there will be a bunch of arguments with this possibly telomeropathy associated with this family history, and then you take the best decision for the patients. So I just like to cover very quickly this study. It was an amazing study done by Jean Soulier in Saint Louis. Basically, Jean Soulier is the specialized for Fanconi patients. So there was many patients who were referred to him for Fanconi testing, and I mean, what he was looking on from years is that sometimes Fanconi was negative. So it was not Fanconi, but there was some clues making thinking that those patients might have a syndromic presentation, a gene-related BMF. There was some clues because there was some family problem, because there was other relatives that were sick. And so in those patients that were not Fanconi, it did a tremendous job to look for gene and to discovering gene. So it was 179 patients from 173 unrelated families. It was young patients, mainly pediatrics, and he was able, as you will see, to find in half of the patients a gene outside Fanconi explaining the BMF. So there was a huge proceeding work with whole exome sequencing and then a very straightforward analysis to check for VUS, to check for the variants that was already reported in database, and then to come back to those patients to discuss, to see if those genes might be implicated in the disease. I'm not gonna enter into details, not only because of matter of time, because also I'm not so familiar with and I don't want to say mistakes, but basically on the 179 patients, he found 28 genes who were really suspicious to be causes the disease. And those genes were carefully analyzed and finally identified as causing disease. That was the first publications on 79L patients. He found 16 patients, 20% of those patients that were presenting with this disease. Of course, telomeres were one of them, but telomeres was already known at that time. We find some hematopoietic genes like GATA2, GATA1, RANKS1, ATV6, MECOM and stuff, and that was also something very important. Ribomosomopathy was also involved. You know that Shishman diamond syndromes might evolve to pancytopenia. It might have also a cause of bone marrow failure. He was finding some DNA damage patients, about 11 of them, 13%. And as you can see, that was tremendous improvement in the world of BMF, because then we could set up a gene panel with all those genes. That was really something that was changing our life on a daily care, because then when we have a very strong suspicion of the disease, we were able to run for this panel. So this is a short description of the age-related presentation of inherited disorders. For, let's say, very young age patients, you will have some megakaryocytosis evolution. You know, those patients with MPL mutations that might evolve to BMF. So you have to think about, and the diagnosis is obviously from a germline DNA. The MECOM syndrome is very frequent, and you have to help from MRI to do it. Then when you're coming to the kids' age, this small SAMD9, SAMD9L with monosomy 7 and against DNA. Fanconi, I told you, break-edged, and then FANCD test. TPHO is something new. Very rare, very rare. You can think about few patients reported. We are trying to report ours, but I mean, this is amazing. Because you have a mutation in THPO gene, you have a pancytopenia, and then if you are bringing the thrombopoietin, then you have a recovery of everything. So that's something that, in a way, avoid patients to be transplanted. So that's the reason why it's so important. Telomeropathy, I mean, telomeres and DNA I show you, and Schwarzman sometimes is forgetting. For the adult and young adolescents patients, we had some very good surprise, very good. Well, we did identify, because it's not a good surprise for the patients, but we did identify those so-called ERCC6L2 syndrome. And I have a family of this. I have a brother and a sister. I remember perfectly, because those patients at the beginning was 20 years ago. We are very reassuring to the parents. I remember Liane Gluckman, she's always saying the story that she was transplanted the first daughter, and basically the parents were asking us, well, is this sure that it's immune mediated? Is she sure that it's not gene related? And it was not a Fanconi patient. It was not a dyskeratosis congenita. The presentation was quite nice. So yeah, she was saying, no, I mean, it's a rare disease, but there is no reason that there will be another one in the family. And basically, the brother that came 3 years after was also having the genes and presenting the disease, and was transplanted from a 10 out of 10 unrelated donor. So both of them are doing wonderfully. And now we are, of course, laughing about it in a way. And that's the paper from John that was identifying those genes. Remember 5 years ago when we came to the family saying, well, we found what you got, and we found why we were presenting this disease. It was really a strong moment. And yes, and then you have all this, as I was saying, to the genetic consile not to happen again. In adults, I mean, this is mainly telomeropathy. There is very few patients diagnosed with Fanconi. Those patients with cancer, 30 years of age, mainly head and neck. Then, of course, you think about Fanconi, but most of the time, this is telomeropathy. Then, why I put this? It's just because at the time, you don't find genes, and you have to treat the patients, right? So sometimes, I mean, as I was telling to you, it's not so clear, but you need to do something. So if you think the patients as more favoring an immune-mediated disorders, then you are running to immunosuppression. And this is the best test, because if the patient is responding, then it's an immune-mediated disease for sure. But if he's not responding, then what to do? So we have this huge program in France that is called the Plan France Médecine Génomique, where we have two platforms, North and South, who are doing whole exome sequencing in all those patients who are highly suspicious to have an inherited disorder, but have not been found yet. So we are sending germline DNA from the patients and the parents doing this so-called trio. And we have this program going on at the moment, funding by the state. So it's quite, good for the patient, but we are not always finding the genes. But anyways, this is something that is ongoing at the moment. Then in terms of management, I mean, so I'm not going to spend many times on this. This is the same if it's immune mediated or inherited. If it's severity, severe, very severe, or patients with moderate aplastics and transfused, then you should go to treatment. Those treatments, I spent some time with you already. We spoke about this immunosuppression or transplant. I think I never done a seminar on transplantation in inherited disorders for Mumbai group, but basically on the way of PNH or acquired aplastic anemia, you know everything because we speak about. For inherited disorders, we are mainly going first to androgens because we know that transplant might be toxic. And then if androgens are useless for Fanconi and telomeres, especially, then we're going to transplant. For Fanconi, I should confess that more and more for sibling donors and match-unrelated donors, we are going straight forward to transplant because the results are so good. And then, of course, you see the difference in terms of long-term follow-up because inherited disorders, you're going to have to closely following these patients, while for the immunosuppression or the immune-mediated disorders, the complication are less. So just to conclude, on all what I said, and I hope it was not too long, there are many situations. So first of all, doing the diagnosis of aplastic anemia first. And then if there is a PNH clone or a 6PLOH, if you have access to it, I mean, there is nothing much to say. It's an acquired disorder. If the patients have a young donor, if he's less than 40 years of age, he should go to transplant. If he has no donor or not eligible to transplant, he should go to immunosuppression. The other situation in adult patients is those one who don't have a PNH clone or a 6P LOH. And then you have to carefully question them, examine them, see the CBCs, is there any family history, the hemoglobin F, the alpha-fetoprotein, the physical exam. If all of those things are normal, then those patients should be considered as immune mediated. They don't need any panel. They don't need any germline testing, and they should go to treatment, as I was telling to you before. Then we come to the hardest part, the pediatric patients without the PNH clone. So now, honestly, we are doing germline mutations for everybody. But I was thinking we should at least be a little bit reasonable. So what we were doing some time ago is that, of course, we are doing the breakage test, first of all, to eliminate the Fanconi anemia, because this is the most frequent disease, inherited BMF worldwide. And then if it's negative, what we were doing is that if the patients were older than 10 years of age, we were coming from for telomeres, and then afterwards, if it's negative, we were going to NGS. For less older patients, less than 10 years of age, and we are doing panel for everybody. We were doing, because again, I think since 2 years, we are doing panel for everybody. And then, of course, this is not a straightforward dichotomy. You have some patients who are adults, they have no PNH clone, but they have a family history, or they have a cancer. And then, of course, you're coming back to the inherited side. And that's something that should obviously be discussed. And the other way around, if the panel is negative for young patients, then you're coming back to the immune-mediated disease. So I think this is it. So basically, definitely, who should be tested? All patients aged less than 10, and I tell you that honestly now we are doing all patients aged less than 18. At least for the patients between 10 and 18, we could first of all eliminate Fanconi and telomeres. And then for your patients, is really if you have a sign, a cancer, something in a family that make you think that it might be an inherited disorder. And with that, I'd like to thank all my colleagues who are working hard with me on the routine care, on the research care, on the transplantation side, on the aplastic side. And thank you very much for your attention. And happy to take questions, and hopefully I could reply to them.
Thank you so
Thank
much.
you.
Fantastic lecture as always. I've heard you before also. You are too good, sir. Thanks a lot. Sir, we've
Thanks
got
so
some five,
much.
10 minutes time. So should we go with questions as a session? As you wish, sir.
Okay, we can go whatever you want.
Okay, so we have first Dr. Sunil Bhatt. Your question.
First of all, excellent. Can you hear me, Amit?
Yes, yes, yes.
Yes.
Please.
Right. First of all, thank you for an excellent overview. I think it was simple, crisp, and to the point. I have three questions, small ones though. One, I think, you showed us the algorithm where a PNH clone kind of differentiated whether we need to do the workup or not. So less than one and more than one. So I just wanted to, kind of ask you, especially in the pediatric practice, is that reliable? If you get a small PNH clone, 2%, 2.5%, 3%, do we still skip the workup for the involved, bone marrow failure syndrome? So that is one question I have on the algorithm which you showed. Second, Professor Latour, you made a comment on if you diagnose a bone marrow failure syndrome, and you would also want to give a trial of androgens, which is of course kind of a practice for non-Fanconi, especially pterominopathies. But in Fanconi anemia, if you have a phenotype, and you have proven Fanconi anemia, would you still want to do that, or directly proceed with transplant while they're well, especially when they have a matched donor, whether related or unrelated? So that was the second question I had. So if you take these two, I have one more after that. I think I won't confuse it too many with too many questions. So these two, if you could just
Yeah.
put your thoughts on.
So for PNH, it's really depending on your laboratory. But basically, if there is a PNH clone, we have a kind of homogeneous laboratories in France who have some guidelines. So we know perfectly that when they are saying there is a PNH clone, there is no doubt. So 1, 2, 3%, yes, definitely. The only thing is that we have to still to be very systematic. And if you have 8-year-old patients with a plastic anemia with a PNH clone 1, 2, 3%, I would definitely be in favor of an immune-mediated disease, but it's not the reason why you should not proceed to all the rest. Asking the family, doing the physical exam, doing an ultrasound to see if everything is okay, just to be sure. But this is really, really in favor. I have 2 patients in my entire career, and we were discussing this at the meeting. There is 2 others from United States with a Fanconi and a PNH clone. So this is really exceptional, first. Second, Fanconi, you are definitely right. If a patient with Fanconi anemia has an indication for treatment, namely severe or very severe aplastic anemia or moderate transfused, and you have a sibling donor or a match-unrelated donor, you don't need androgens. You go directly to transplant. If a patient don't have a suitable donor, haplo or mismatch, then we are trying androgens because we know that the toxicity of those type of transplant is higher.
And the last one was, in the context of the workup which is done for identify the germline mutations. We fortunately in India have got good access to it. They're pretty, inverted comma, cheaper now as they used to be before. And for us, it's become more of a cheap and reliable workup, modality, and we do have access to these germline mutations now more readily. But what we come across, and I think you probably touched upon that briefly, was variants of insignificant significance. Finding nothing is one, and then finding prune, mutations is another. But then you have something in between the gray. I just wanted to, and sometimes we ourselves do not know how to deal with them. Families have questions. Just wanted to ask, in your practice, how to resolve those ones, which are in between in the gray area. Thank you.
They result in headaches. So basically, it's kind of email that we are sending all together. And we are, of course, analyzing the genes, if it's VUS or if it's something possibly involved. So we have the MDT meetings first and 3 Wednesdays of the month in France. And you are more than welcome. We are discussing those cases collegially all together and then take a decision. It's not an easy one. This is the most difficult case, and it's not something that we could guidelines. It's really case by case. So we are discussing them, and again, you are more than welcome. Or we could do it by email, but I don't see any other way of doing it for the moment.
Thank you.
Thank you, Dr. Sunil. Agarwal sir, your question, please.
First of all, thank you so much, sir, for sparing your time and joining us. Dr. Agarwal. 2 questions related to Fanconi's. One is, after transplant, what is the median survival of Fanconi's anemia patient because of other problems? And this question, and then I'll ask you the second.
So at the moment, with about 15 to 20 years median overall survival post-transplant, the main cause of death is related to secondary cancer, and there is a very, very straightforward association between secondary cancer and death. So that's the reason why we are following those patients every 6 months, hourly, gynecologically, to try to be able to take the cancer at the stage very limited and to propose surgery. So if you are doing chemo, radiotherapy is not just possible, and you have to doing chemo, it's very difficult. So that's the reason why we are following straightforward our patients. But yes, the median overall survival post-transplant is about 15 to 20 years maximum.
Thank you. Second, when you're getting a sibling donor, if there are no physical stigmata and the stress cytogenetics is negative, that's enough to take him up as a donor?
So theoretically, yes. But in my center, we're always checking. I cannot say something else because that's what we are doing. We are always screening the donor for the gene.
Thank you. Is stress cytogenetics not superior to the genetic testing for Fanconi's?
The
Both?
bra you mean the FANG today, yeah, definitely. Yeah. We are doing brackage tests and FANG-D2 tests for all donors.
Thank you. Thank you.
Thank you, sir. Ma'am, your question. Yeah, you.
Gayatri here
Yeah,
from Hyderabad. Thank you. Really, really enjoyed the talk. I have two questions again. One is, would you have a protocol that is age dependent? Would you say that up to the age of 40, we would, because earlier the Fanconi registry did have those suggestions that patients with a plastic up to the age of 40 should get screened for mutations and over 40 for the acquired PNH and so on. Do you think that holds true now? That's my first question. And a second question would be, if the stress test is positive, do we still need to go ahead with the gene testing?
So for the first one, at the moment, what we are doing is a panel for all pediatric patients. I should confess that since 2 years, so all pediatric patients with BMF are testing. For the other ones, if they are PNH negative. For the other ones, we are really testing only patients who have some arguments to be tested, a family history, a cancer at young age, stuff like this. If not, we are not testing. And then the second question, I don't remember.
So the first one, would you say that the cutoff age of 40 still is kind of okay to for the planning the workup?
There is very few patients after 40 years of age with inherited disorders, that's for sure. But we still have some patients that we are discovering, but it's really noisy. It's patients with AML, it's patients who are toxic with chemo or with a head neck at 35, 40 years of age, and you have something to say that it's a Fanconi patients. On the other way around, I remember your questions for brackage test. It's enough. I mean, if the patient is very young, he has some very small, and there is a kind of typical presentations with a brackage test positive, that's okay.
Thank you.
Thank you, ma'am. Dr. Ankur, your question, please. Yeah, Dr. Ankur.
Good afternoon, sir. So excellent presentation, sir. And actually, I learned a lot of things practically, probably. So just one question: what is your experience or opinion about doing flow cytometry like P53, CD34, or telomere by flow fish, or the phosphorylated H2A, which is basically a marker for DNA double strand breaks? So can we go through it, and will it help us?
So you mean for the telomere size?
40 telomere length by flow fish for CD34, or doing P53 mutations by IHC or by the flow cytometry, sir.
Yeah, I know.
To differentiate between, yes, sir.
For the moment, this is still on the research side. We are really focusing on a routine assessment of flowfish telomere lengths, but for the rest, honestly, we are for the moment, this is research side, but that looks like very interesting, yeah.
Thank you, sir.
Thank you. Dr. Arihant?
Yeah. Thank you, sir, for your insights. So my first question is kind of an extension to Dr. Agarwal's question. And as you said, if you detect a germline, you would always check that in the prospective donor when you are intending to proceed to a transplant. But there would be scenarios which are very common where the donor is also having the same mutation, but he or she is absolutely asymptomatic. And the other option is a haplo And most of the times we are doing a PTCY haplo where the cyclophosphamide doses are uh, prohibitive, particularly if it is a telomere biology or a Fanconi phenotype. So in that case, if you detect that asymptomatic donor having a germline mutation, would you, and he's like good 5-10 years old, and he's absolutely asymptomatic, would you still take the risk of taking that donor for transplant, or what would be your approach?
So I'm a deeply fan of the fact that a gene only is not able to give a disease. So in other words, we have environment, we have disease, we have food, we have everything. I think it's not a well. So this is possible that for the donor it won't be a problem, and we have also, especially in telomeropathy, some prevalence of the disease that is not the same with the same gene in the family, and even not the same in terms of organs. We have some patients with blood problems, with liver problems, with lung problems. Saying that, I would say that taking a marrow that you know it's mutated in a patient who was these problems with these mutations, we will discard the donor, definitely. So we did already, and in that situation, we are taking unrelated donors because we are afraid that this gene mutated that has already had been a problem in the recipients will be again a problem if we are taking this donor as a donor.
Thank you. And the other scenario which we sometimes face is that the gene which is kind of documented is autosomal recessive in the inheritance pattern, which is known, but it is manifesting as an aplastic phenotype and no other physical stigmata. And we do not have a partner gene. So in that case, how do we label that? Would we label it as an acquired phenomena or an acquired inherited with a acquired second hit, or how do you approach those cases?
Very good question. In the middle. No, there is for the moment not good nomenclature for it, but you make me think to something else, is that when you have an autosomic recessive genes, we are not discarded obviously as a heterozygote FA patients. So FA donors, if a donors in terms of Fanconi anemia is having the genes as a heterozygote situation, there is no problem. For the one that you are speaking about, yeah, it will still be genetic because in the end you have no the other alleles, but it's a very specific situation.
Thank you.
Thank you, Dr. Arvind. Sir, we have got just 3-4 questions in the chat box. Should I read for you?
Yeah, please.
The first we have is from Dr. Vinay. What is the role of retic count in the diagnosis of inherited bone marrow failure syndromes? Reticulocyte count.
There is not much than severity. This is not something that is going to orientate with one or another disease. So it's just a severe criteria to make the patients know if he has a severe, very severe plastic anemia.
Thank you, sir. Another question is from Dr. Mona Vijayaran. A patient of myasthenia gravis develops aplastic anemia with a large PNH clone, and on NGS testing, she has SMAD9 mutation with VUS. She is planned for haplostem cell transplant, and her donor is again SMAD9 heterozygous mutation positive. Should we consider that donor?
What is the mutation on the donor?
SMAD9, SM89, SMAD9.
But it's VUS. It's supposed to be VUS, right?
Yeah, SMAD9, what you showed the mutation, the first very common mutation, which is an SM80. SMAD.
Yeah.
SMAD9.
No, I think we will proceed. Yeah.
Okay. And another question is from Dr. Kannan. For all adult patients with aplastic anemia, would you screen for telomeropathy?
No. We are screening for really patients in case PNH clone is negative, and we have no clues, no pigmentation, no skin involvement, no leukoplakia, I mean, for all those patients, we're not screening. We are just screening for patients where we have something.
Thank you, sir. And what do you do for those patients, sir, which comes as positive?
For telomeres in adults,
Yes. If they
it's
come
a
as
night.
telepathy
It's a
positive.
nightmare. It's a nightmare because telomeropathy and transplant are doing badly. We are beginning with androgens, trying to do as much as we can. We recently published a paper on telomeropathy and transplantation, and basically half of the population died, and the other one is suffering from very severe chronic GVHD. So transplantation in telomeropathy, even in sibling and match-unrelated donor, is not doing well. So we are really proceeding to transplant when we cannot do something else. Young patients highly transfused or patients transformed in AML or in MDS. But for the other ways, I mean, telomeropathy and transplant is a nightmare. Really different from Fanconi patients.
Exactly, sir. Another question from Dr. Chandima. A child with heterozygous FANG gene mutation should be treated with immunosuppressive drug or androgen if a sibling donor is not available.
So first of all, heterozygosity in Fanconi patients should not be the cause of the disease. So it's a more difficult case. But in that situation, if it's a child, he has a match-unrelated donor, I will proceed to transplant. If not, I will probably proceed to androgens. Because I would say we're more on the inherited disorder side. But I mean, like this, it's difficult to conclude in 2 seconds.
Good, sir. Another question from Dr. Nutan Joshi. For those patients without any physical abnormalities, NGS shows some VUS mutation in the TERT gene, TERT gene, but telomere length is less than 1%. Do you still modify the conditioning regimen during transplant?
So it's a very good question. These typical patients we are discussing in MDT, and I will be more than happy if it can be sent to us, because then we will look for that gene, we will look for our experience with that gene, and then we will give advice. I cannot like this giving an advice and then making patients at risk, but we can definitely discuss it with our geneticians specialized, Professor Kananji, sir. We can help, no worries. But I would prefer this way of doing than giving an advice and making mistakes. But this is typically the case. Telomere length is very low, the genes is vast, we don't really know what is gone. And then Professor Kanji so will look to the genes, see if it has been reported, see if it in her experience it might be pathogenic or not. If there's not another gene that has not been detected yet because it's not published. So this is typically this kind of things that we need to discuss by email or by MDT.
Thank you, sir. And the last question from Dr. Jyoti Sauni. She has two of the cases. One is 14-year and 23-year-old severe refractory aplastic anemia, which has been transformed to acute myeloid leukemia after 4 years. Now, should these patients be on yearly surveillance for clonal evolution?
Clonal evolution for what? They've been transplanted, right?
No, right now they have been transformed to AML. So when the patient was in aplastic anemia stage, so all the patients with aplastic anemia should have tested for clonal evolution yearly. So
Yes,
for
we
AML.
are doing for inherited disorders. We are doing yearly marrow aspiration examinations with obviously panel and karyotypes, and for acquired disorders we are more on 18 months, 2 years examination, and we are doing it systematically if the counts are dropping down.
Thank you so much, sir. Sir, you have any other question? Agar sir?
Rihant has got.
Aryan, Dr. Aryan, please.
Any experience of using TPO-RAs in telomere biology disorders? Are they like absolutely contraindicated, or they don't do, or there's no experience, or they don't work at all? Because sometimes we are not able to transplant all of them, and as you said, transplant outcomes are uh, uh, not very good, and sometimes thrombocytopenia is the major problem. So
No, I mean, there has not been published studies positively using TP receptor agonists in inherited disorders. There have been this Fanconi study from NIH. I never see the paper. But anyway, you may try, but please stop at 3 months if it's not working. And it's just this. You may try because you don't know what to do, right? And we are all in those situations and we want to do something for our patients. So I could not say not to try because there have been some positive cases, but overall the studies for the moment have been negative. And again, I cannot remember because there was a formal clinical trial from NIH with Fanconi patients and a trauma pack. I don't know it has been published. It has been presented for sure at ASH 2 years ago, but I don't see it published yet. If someone knows, anyway, I would try, of course, because we want to do something for our patients, but I would also stop if it's not working after 3 months.
And does that risk accelerate the process of clonal evolution because these patients are already at risk?
There is not enough patients to answer to the patient's inherited disorder side. For the acquired side, the response is no. This is accelerated, already present clonal evolution. So in other words, that's been published by NIH. It was a blood paper 2 years ago. That's what we are trying to submit at the moment for the RACE trial. If you have some already known driver mutations, the patients will transform, but for those ones who did not have any problems, they will be okay. So there is I would say higher rates of clonal evolution in patients who would have transformed anyway some years later. So no higher risk overall.
Okay, thank you.
Thank you, Dr. Rian. Dr. Fahima?
Such a beautiful talk, sir. It was so crisp and lucid. Really, thanks a lot. Cleared a lot of our doubts. I just have a simple question in my routine practice to ask you. Patients with IBMFS and mild to moderate cytopenias, is there any preference of androgens for specific syndromes or specific cytopenias? What do you prefer when thrombocytopenia is a worrying cytopenia or anemia is a cytopenia? Of course, we know that we prefer danazol with girls and use the rest for the boys. Is there any specific thing for specific syndromes or specific noticeable cytopenias? Thank you.
It's a very good question. I don't have clues on that, and I don't see any papers published on the type of lineage and the type of androgens. We don't have this problem in France because we have access only to danazol. But that might something be run on a large number of patients. They will not have any reason that it's working more on one side than another. But anyway, that's something we could assess scientifically speaking. I didn't see any published studies on that.
Thank you. Thank you, sir.
Thank you, Dr. Fahima. So anybody has any other questions? Any discussions? As I finished all the questions from the chat box. Well, so thank you, Professor. Wonderful lecture, wonderful talk, wonderful discussion, and a wonderful time with you in Paris this time, sir.
Thank you very much for your invitation. Have a good day.
Thanks a lot.
Bye-bye. Bye-bye, everybody.
Yes, sir.
Thank you, sir. Thank you, Kurana, sir. Thank you, Professor.
My great
day.
pleasure. Great pleasure.